Welcome to the lecture for Crisis Intervention. I'm talking about Chapter 5 of Aguilera, which addresses PTSD and ASD, so post-traumatic stress disorder and acute stress disorder. But before we get to talking about the role for crisis intervention in helping individuals with these diagnoses, with these kind of characteristics, let's talk a little bit about what these diagnoses look like. So DSM-4-TR criteria for PTSD. Of course, the first criterion is experience of a traumatic event. Right? So, a trauma, to qualify for diagnosis of PTSD, is when a person experienced, witnessed, or was confronted with an event or events that involved actual or threatened death or serious injury, or a threat to the physical integrity of self or others, where they experience fear, helplessness, or horror. Okay, so that's quite a lot for one criteria, so let's kind of break it down a bit. So the first part, they experienced or witnessed, or were confronted with. So it doesn't have to be something that happens directly to you. So seeing or hearing about something horrific could lead to PTSD. As kind of a side note, doing crisis intervention work may lead to secondary traumatization for caregivers who are listening to clients' stories about the horrific events that they're dealing with. And there's a whole, we'll talk about that more later when we talk about therapist burnout. Just kind of know that secondary traumatization is a risk that is kind of a danger for people working in crisis intervention and therapists in general that are listening to kind of other people talk about their traumatic events. Okay, so you experience it or you witness it. The next part, most people get death and injury, but some people struggle with it. What do they mean by that threat to the physical integrity of self? And I think what this is getting at is things like, well, at least two different things. One would be rape, which may also involve injury or death, but may not involve injury or death and still involve a threat to the integrity of the self. So it's like your idea of yourself and your conceptualizations about who you are and how the world works may get shattered by something like a sexual assault or any other kind of assault. Might also involve, for some people, kind of really severe public humiliation. If it rises to a level where you feel like yourself, your ego might be destroyed or irreparably harmed. So it's not just getting shot or having things blow up that might lead to PTSD. These other things might lead to these other symptoms as well. If they do, then it very well may be PTSD. And the last bit of the definition of trauma is that fear, helplessness, or horror. And so this is like when the trauma happens, soon after you have these feelings. And sometimes these feelings might not be obviously present at the time of the traumatic event, especially for individuals like police officers or soldiers who may be trained to suppress thoughts or feelings of horror and fear or helplessness. They're taught to go for it, don't think about it, and they may really not experience those feelings in the moment. Doesn't mean they don't have PTSD. And it might be what happens is two things. One, it could be they don't suppress it completely, and so maybe they suppress the cognitive part, but they don't suppress the physiological part. So they still have this physiological emotional reaction, even if they're not aware of it. Or it could be even if they suppress it completely. Whenever they're recalling what they went through later, they might experience the horror, the helplessness. And so for some, it's possible that remembering an event might actually be the trauma that does the damage more so than the original event. So remembering the bad thing that happened, if you then experience the horror and the helplessness and the fear, then that might be the originating event for the PTSD. Okay, the second set of criteria, persistently re-experiences the trauma in one or more ways, at least one way. Could be through memories, and typically we talk about intrusive memories, and we all probably have experienced intrusive memories at some point in time. There's just something that you don't want to think about from your past, but it keeps kind of popping into your head. And for an individual with PTSD, they may have intrusive memories of the traumatic events. They're re-experiencing that traumatic event and remembering it when they don't want to, which is slightly different than reliving. So reliving is kind of a more intense type of remembering. And reliving the trauma might include hallucinations and or illusions. Most frequently, reliving is thought to involve something called dissociative flashbacks. And these dissociative flashbacks are really different from intrusive memories because of the experience of dissociation. Right? And with dissociation, there's a disconnect in cognitive processes that's qualitatively different from simply remembering something. Often the person temporarily loses a sense of place or time. They're not sure where they are, and they may feel as if they're back in the place and or time of the traumatic event while they're remembering it. So it's not just, oh yeah, I'm kind of replaying the movie in my head. It's feeling as if you're there. So a bit more vivid than simply reflecting on memories. Another way that people might re-experience a traumatic event, disturbing dreams with some sort of emotional content related to the trauma. And then the last one would be psychological and or physiological reactivity to triggers associated with the trauma. So any kind of stimuli that remind one of the trauma. They may have kind of psychological reactivity where they feel distressed, anxious, angry, dysphoric, when they encounter something that's symbolic or representative of the trauma. And typically, this kind of psychological distress is accompanied by physiological reactivity. But they also might have physiological reactivity without psychological reactivity, where they have changes in heart rate, respiration, sweating, and typically these things go together, but they may occur independently of one another. It may be harder to work with somebody if they have the physiological but not the psychological, because they don't connect the physiological reaction maybe to the traumatic event, and they think maybe they're just going crazy. They don't, or maybe aren't even noticing that their heart rate is up whenever they encounter certain stimuli. It can be harder for them to figure out what their triggers are. Okay? So there's a traumatic event. They re-experience that traumatic event in at least one way, typically more than one. And then they experience 3 or more symptoms related to avoidance or general numbing. And it's avoidance of anything related to the trauma or kind of a general emotional numbing. We'll talk about all the different types of symptoms, but kind of big categories of symptoms. One piece of this is the avoiding trauma-related stuff, and this is not wanting to talk about the event, not wanting to think about the event, avoiding people, places, activities that might remind someone of the event or where they might be asked to talk about it. And there may be some sort of unconscious avoidance where they may not remember certain aspects of the trauma, which might be kind of a dissociative amnesia piece there. And then there's also, so they don't want to talk about it, think about it, go anywhere that might remind them of it. There's also this, related to that, this kind of overall withdrawal, which is a way of avoiding, obviously, where they're maybe not interested in doing many things. They feel estranged from others, and they're kind of pulling away from people. It may be 2 things that might explain this symptom. One, they may feel that other people wouldn't understand or be able to deal with kind of the stuff they're going through. And 2, it may be they may fear that other people will want to talk about the event, and so if they pull back on a conscious or unconscious level, it makes them a bit safer, and they're able to avoid talking about these unpleasant things. And then beyond that, they also kind of withdraw generally from emotional experience, which is that general numbing. And they may be unable to experience the full range of emotions, including kind of loving emotions and positive emotions. And it may be that the person feels a bit betrayed by their emotions, or it could be that they feel afraid of their emotions because of the intense emotions that come with the fear and horror and helplessness. Sometimes it seems like it's easier to cut off all your feelings than to try to just shut down some of them. Like I'm not going to feel afraid anymore, and I'm going to shut that part of me down, but I'm going to leave this other stuff open. That's hard to do. Kind of really pulling back from all emotional experience might be more manageable for some people, and one way to avoid those negative feelings. So 3 symptoms though of some sort of avoidance and or general numbing, and then 2 symptoms of persistent arousal. And again, we won't go through all the various symptoms, but typically broken into to three categories, which for some reason I only list two of them here, but I'm sure you can remember right down the third one. The first being physiological, so things like sleep problems, exaggerated startle response, emotional, so anger outbursts, and then the third one, which for some reason didn't list here, would be cognitive, so difficulty concentrating, hypervigilance. Hypervigilance is where people are always on the lookout for potential danger. So, some of the soldiers that come back and they were driving convoys, now when they're driving down the highway, they're looking left, looking right, and they see a cardboard box off to the side, and nobody else would notice, maybe, but they notice it, and they know exactly what it looks like, and they're thinking, okay, what's in that box? Part of them knows nothing's in that box. I'm in clean Texas now, but there's a part of them that still is on the lookout for dangerous stimuli. And the last bit of criteria for PTSD are related to kind of the timeline. And so to qualify for PTSD, you need to have, this kind of constellation of symptoms for at least 1 month. And something I want you to kind of think about, well, why might that be? Why do you have to have symptoms for a month? Why not just 2 weeks? And also a quick side note, I think the Aguilera for some reason says 3 months, but that's incorrect. It's at least 1 month of symptoms. And then you may or may not have delayed onset. Sometimes people won't experience any symptoms of PTSD until 6 months or more after the traumatic event. And if they do have, if they don't have symptoms for, at least if they don't have all the symptoms, put it that way, until 6 months, it's delayed onset. And some people have no symptoms for 6 months, and then they have full-blown PTSD. More commonly, people with delayed onset had some subsyndromal symptoms, where they had some symptoms of PTSD, but not enough to meet full criteria. And over time, the symptoms increase to reach that threshold where they meet diagnostic criteria. And sometimes it seems like experience of depression and or alcohol abuse might exacerbate or quicken that transition. So people that there's a traumatic event and they don't have full PTSD symptoms, but then they start abusing alcohol, maybe to deal with some of their symptoms, and then they go into having full PTSD. So the alcohol may be kind of an attempt at coping that pushes them to meet full criteria. Okay, so that's PTSD, post-traumatic stress disorder. Related to that would be acute stress disorder, right? And so just kind of looking at its diagnostic criteria and comparing them to PTSD. The trauma criterion is the same one as PTSD. There's something that's a little different. There's a requirement for 3 dissociative symptoms. So during or soon after the traumatic event, 3 dissociative symptoms like depersonalization, derealization, which those things may occur in PTSD, but to get this kind of immediate, kind of short-term diagnosis, you have to have some dissociation early on. And then the re-experiencing criteria is the same as PTSD, at least re-experiencing at least one way. The avoidance numbing criteria, it's the same set of criteria, but you need fewer of them. You just need one avoidance criteria. Of course, some of the dissociative criteria that you have to meet overlap a bit with the numbing ones. But just one more avoidance one, and then the arousal, again, same criteria, but just one, not 2. And then the main difference between acute stress disorder and post-traumatic stress disorder, obviously, would be the timeline. For acute stress disorder, you have to have the symptoms for at least 2 days and no more than 4 weeks. Once you've had the symptoms longer than 4 weeks, there's a determination of, okay, well, do you now meet criteria for PTSD? And then the onset of symptoms must be within 4 weeks of the trauma. So even with PTSD, you might not have symptoms for 6 months, but with acute stress disorder, to meet criteria for this kind of acute disorder, for lack of a better term, it has to start pretty soon, pretty proximal to the traumatic event. But again, the main difference is time. And the reason why this diagnosis is here is to kind of catch those people who will have PTSD eventually, because the thinking is, okay, if they have these symptoms, they're at risk for PTSD, and we can't diagnose them with PTSD now, but so let's give them something we can diagnose them with so we can get them some treatment. But it's important to note that not all individuals with acute stress disorder go on to develop post-traumatic stress disorder. Many do, but not everybody. Okay, now that we've defined these diagnostic categories that we're going to talk about, let's talk about the role of crisis intervention in treating people that have experienced trauma and people that might meet criteria for these disorders. So there's two domains of concern we'll address. The first being prevention of acute stress disorder and or PTSD. So someone experiences a trauma and maybe they meet some criteria for PTSD or criteria for ASD. What can we do to keep them from, experiencing more pathology at whatever level they're at? The other would be crisis intervention in the context of PTSD. So not the kind of the traumatic event as a crisis, but people with PTSD, if on down the road while they're under treatment or not under treatment for the PTSD, if they experience some other crisis, how does that make crisis intervention work different? So we'll start with the first, prevention. And first it's important to kind of identify what we mean by prevention. And there's primary, secondary, and tertiary, at least, but we'll focus just on primary and secondary prevention because that's really the role for crisis intervention with PTSD and with other things. So primary prevention is whenever you have efforts aimed at preventing members of a population who may be at risk for a disease or problem from developing that disease or problem. So this would be, everyone that's exposed to trauma gets intervention because being exposed to trauma puts you at risk for acute stress disorder or post-traumatic stress disorder. So if we had a primary prevention program, everybody who had a traumatic experience would have to go through some intervention. Secondary prevention, a bit more focused, is when you have efforts aimed at preventing the worsening or full development of a disease or problem for individuals who are showing some symptoms or signs already. So this would be individuals with some symptoms of PTSD get intervention, or maybe people who meet criteria for acute stress disorder, they get the intervention to help prevent PTSD. That would be secondary prevention. So you might be asking yourself, hopefully you're asking yourself, well, which one's better? Which should we do, primary or secondary? Well, it's important to note that we have a better understanding now than we used to, that not everyone who's exposed to a traumatic event will develop PTSD or acute stress disorder. Right? People are remarkably resilient. They can go through horrible, horrible things, and a lot of people emerge. They're not happy-go-lucky fine right away, but without therapists helping them, if they have some other pieces in place, most people are fine. They're able to kind of function at the same level they functioned before and have full, fulfilling relationships and lives without us jumping in and trying to save them. And we've identified some risk factors in terms of who might be more likely to get PTSD following a trauma, or what types of trauma might lead to PTSD more than others. So maybe we might be able to focus our intervention more. But even though we've identified these risk factors, we've got pretty poor predictive ability with these risk factors. So they account for some variability, but not enough to where we can reliably predict who's going to get PTSD and who isn't, based on the presence or absence of these risk factors. But nonetheless, the argument's out there that if resources are limited, they should be focused on secondary prevention rather than primary prevention. Again, with the idea being that not everybody needs intervention, so let's wait till people develop some symptoms, and then we can give all resources to those folks rather than spreading ourselves too thin and giving resources to everybody if the majority of people won't need any resources. But in an ideal world, probably should be both, if at all possible. With especially an emphasis on education in the primary prevention, and then more kind of therapeutic intervention for secondary prevention. One model that you may have read about that is kind of a primary prevention model would be the critical incident stress management model, CISM, which was originally developed as a primary prevention model to prevent secondary traumatization among emergency workers. You know, your first responders, police officers, firefighters, hospital workers. It was designed to employ a multi-component program consisting of small group crisis intervention, large group crisis intervention, these kind of town meetings, individual crisis counseling, face-to-face or on telephone, family crisis intervention, and then also these kind of mechanisms for follow-up and referral for formal assessment and or psychotherapy. So that was kind of the full model of CISM. One component of that I kind of went over quickly there was, there's some small group discussion. And the small group is the critical incident stress debriefing, the CISD. And unfortunately, people haven't used the full CISM model. They've taken that one piece and said, okay, well, let's do this one thing, and it'll be just as good as the larger model, which it doesn't seem to be. But frequently what happens is people use just this critical incident stress debriefing as a standalone intervention. And it's typically a single session discussion of the traumatic event and associated emotions for anyone that experienced a potentially traumatic event. And they frequently do it in a group setting. So a unit goes out and there's a firefight, and they come back in, and everybody comes back in the unit, and they have this psychological debriefing where they talk about what happened and how they felt about it, and they're kind of encouraged to talk about how they felt about it. And when you read the literature on this, you may see critical incident stress debriefing, you may see just debriefing, you may see psychological debriefing, and these terms are used interchangeably, but they're not really interchangeable. Critical incident stress debriefing is one type, again, that's part of a larger model. People have done kind of variations of that and just done these kind of group one session talk about feelings things that they call debriefings, which maybe not super true to the original idea of what this is supposed to be. So not surprising that the research looking at this primary prevention technique, especially this brief one session debriefing, has got some mixed results. For the large model, CISM, and even CISD, pretty good support for their use in terms of secondary trauma. Caregivers who see traumatic stuff, hospital staff, for use in a workplace. This seems to work pretty well at preventing development of PTSD or other kind of psychological long-term difficulties. There's less support for the larger model, or especially these one-session debriefings for primary victims, especially if those one-session debriefings are used without any other component. But there's this raging debate in the research literature, as raging as debate among academics can get, about whether or not CISD is good or bad, or maybe even possibly harmful, and probably only harmful if done poorly, which we'll talk about in a minute when we get to some the NIMH stuff. Okay, so primary prevention, secondary prevention, and one of the biggest primary prevention models out there is the CISM, which is used in some shape, form, or another by many segments of our military. But again, secondary prevention may be a better use of resources. But in terms of large summaries of research, fortunately, our government is interested in learning about this. So back in 2002, the National Institute of Mental Health recruited, blanking on the number now, several researchers from multiple countries. So in an international group of experts on PTSD to participate in this workshop, to come up with recommendations for best practices for psychological interventions, and they use the term psychological interventions for survivors of mass violence. But we can probably think about their recommendations apply to survivors of really traumatic events in general, even if they're not violent events. Based on this workshop, they published a report in 2002 that summarized the research as they saw it on these early interventions, and then made some recommendations about best practices, what to do. So first, the evidence for interventions. They said there's some level 1 evidence for the effectiveness of early, brief, and focused psychotherapeutic intervention provided on an individual or group basis for reducing distress in bereaved spouses, parents, and children. So early therapy that's brief and focused, so crisis intervention stuff, can do a good job of helping if somebody gets killed or wounded, the kind of collateral people, the family, spouse, other people, we can do a pretty good job of helping them be less distressed. So we can be comforting. So that's good. Beyond that, even more exciting, for some anyway, there's some level 1 evidence that selected cognitive behavioral approaches may help reduce the incidence, duration, and severity of acute stress disorder, post-traumatic stress disorder, and depression in trauma survivors. Okay, so that's incidence, duration, and severity. So that means may prevent people from having it, may make people have symptoms for a short amount of time, and may make their symptoms less severe using cognitive behavioral approaches. Third, they did address the kind of that debate of critical incident stress debriefing, and they didn't use that word per se, but they said whenever you have a single one-on-one recital of events and expression of emotions evoked by a traumatic event, right? So it's kind of making people talk about the event and their emotions. There's some level 1 evidence that this does not consistently reduce risk of later developing PTSD or related adjustment difficulties. And some survivors, especially those with high arousal, may be put at heightened risk for adverse outcomes as a result of such early interventions. This is when we talk about iatrogenic effects. So it's kind of these single session things. If somebody has a high level of arousal and they're really worked up in the moment, and you're saying, okay, tell me about it, and you're kind of pushing them to talk about the emotions more when they're in this state of arousal before you're calming them down, you might actually make it worse. So if you're going to use kind of the critical incident stress debriefing, make sure you're doing it the right way and you're not misusing it, because it might make some people worse. And then the last thing that they addressed was there's no evidence that EMDR, eye movement desensitization and reprocessing, as an early mental health intervention following mass violence and disasters is a treatment of choice over other approaches. So they didn't say it's bad, they said there's no evidence that this is the best thing since sliced bread and works better than anything else, which would be consistent with some other research that's not published in the EMDR journal, that it seems to be just as good as other kind of exposure-based therapies, but doesn't necessarily have an advantage over other treatments. Okay. So in addition to summing up the research, they made some recommendations. They said the focus of early interventions should be on providing psychological first aid. Okay? And by that, they're talking about reducing physiological arousal. And one thing I want you to be thinking about, and we'll talk about in class, is how do you do that? If somebody comes in and they saw something traumatic and they're freaked out and they have a lot of psychological, physiological arousal, heart rate's going and adrenaline's pumping, how do you help them calm down? So you do that, you mobilize social support, you provide information, you foster communication. Right? So you're not trying to cure them in this one session, you're just doing the first aid. You're not doing the surgery, you're putting on the band-aid, you're bandaging them to get them stable to where other treatment, if needed later, can take place. Right? So it's the idea of kind of psychological first aid. Beyond that, interventions should involve a focus on outreach, right? So offering information or education when visiting individuals that are at risk. So if we're talking about a military population, educating them as much as possible about PTSD, about what the symptoms are, what it looks like, about what is available to help, and what works and what doesn't. Because you're thinking, okay, well, nothing works, why would I go talk to somebody? But if I think, okay, well, see other people have these problems, and then they can help get better. Maybe it's something, if I have a problem, I'll go do. You want to focus on fostering reliance, no, resilience. Sorry, that's a bad typo. Fostering resilience and recovery. So providing coping skills, training, taking care of the bereaved, right? So again, if there's been a loss, helping people recover from that, and then if people are dealing with the trauma, focusing on building on that idea of that there's a natural resilience to people. People can survive things, and helping them realize that they will get past it, they will survive this, and they're not maybe as fragile as we used to think. And we don't want them to see themselves as these fragile or weakened individuals just because they've been through this traumatic experience. So they focus on the positive if possible. There should be a focus on triage to some extent. So you want to identify the vulnerable, high-risk individuals and groups, conduct clinical assessments as necessary, and refer when indicated. So again, this is about prioritizing. If you have a large-scale trauma and you've got lots of people that may need help, you've got to do some triage and say, okay, who needs the most help right now, and do some quick assessment stuff to get people the help they need. Because again, not everybody is going to need the same level of intervention. A single may not need much intervention at all, but you won't know that unless you do some triage work. And then the last thing, and this is purposely last in their list, would be provide intervention. Right, so you want to reduce or ameliorate symptoms and improve functioning. And their recommendation elsewhere in the report is to use cognitive behavioral therapy, because it has the most research support, and this typically involves imaginal and in vivo exposure is one component, and then cognitive restructuring. Right, and exposure, whether it's imaginal or in vivo, is having them confront the things, the triggers that lead to the trauma, and once you experience things enough and don't avoid them, they begin to lose their power, just like with phobic stimuli. So confront the triggers. You may even do exposure to the traumatic event. Think about the memory till the memory loses its power to cause horror, fear, and helplessness in you. And then some cognitive restructuring, which is your basic CBT work, where you're identifying problematic cognitions. Talk about automatic thoughts, or dysfunctional or negative views of the self, world, or future. Identify the cognitive distortions in the automatic thoughts, and then have some sort of rational disputation of the automatic thoughts with Socratic dialogue. So it's kind of, what's the evidence for that? Do you really think that? Is there another explanation for this? Logically working through these things to point out the cognitive. We're not telling them, hey, you're thinking crooked, stupid, but having them talk about and come to their own realization that, okay, I kind of think this, but part of you realizes that makes no sense. And then helping them develop, lastly, a rational rebuttal to the automatic thoughts, so they can tell themselves, which over time will lead to this restructuring of cognition. Right? Something we can talk about more in class if you'd like. So in addition to the NIMH report, which was a big one, another set of researchers got together and published a paper summarizing the research on crisis intervention work following a trauma. And they came up, this is Hopeville et al.'s 2007 article, they came up with 5 key principles of intervention. They said that you should aim to promote a sense of safety, promote calming, which should sound familiar, so safety, promote calming, okay, so some psychological first aid stuff, a sense of self and community efficacy, so again, that kind of focus on resilience, that yes, you can do things for yourself, and the community can do things for itself and can do things for you. Promote a sense of connectedness, which again makes sense given that one of the symptoms of PTSD is this feeling of estrangement. So if we want to combat the symptoms, let's promote the opposite of the symptoms. So promote feeling connected to other people, and you're not alone. And last, which I think is key to therapy in general, promoting a sense of hope. Because again, one of the things that people with PTSD may experience is this sense of foreshortened future, right? Where they feel like they'll never have a family or never have the career they wanted, or they don't think they'll live past 35. And not that they're dying of anything, they just kind of lose this sense of their future selves. So you want to promote a sense of hope that, yeah, things are tough now, and I'm not going to sugarcoat that, but things can get better. They might get better, and if you can hang on to that hope, that can be pretty powerful. Okay. So that's what I want to kind of talk about in terms of prevention of PTSD, acute stress disorder, and even depression. So crisis intervention has a place in doing that, and we don't know exactly what to do yet in terms of the research. I mean, some people think they know what to do. There's not an agreed upon cut and dry formula, but there are a couple of key pieces we identify with the Hobefall et al. Article and the NIMH article, which there's some overlap there, I think, with the emphasis being on that kind of psychological first aid. Okay, but beyond that, we can also talk about crisis intervention in the context of PTSD, which something I want you to be thinking about before we meet is why might individuals with PTSD be at increased risk for experiencing additional psychological crises. So having PTSD versus not having any diagnosis, maybe some other diagnosis, why might they be at risk for additional psychological crises that aren't necessarily directly related to the original traumatic event? Okay, so be thinking about that. But some things to talk about now. There are maybe some unique considerations when working with individuals with PTSD and they have some other crisis. So they have PTSD and now they're going through a divorce. Right? So it's another crisis. Well, one of the things that we know happens with individuals with PTSD is potentially the experience of dissociation. Not everybody with PTSD, but it's a pretty common experience. And once people dissociate, and with PTSD they dissociate to protect themselves, probably it's a coping mechanism during the traumatic event, maybe later whenever remembering or reliving it, there's a dissociation. But once people do that, they're more likely to dissociate in other times of high stress where they're not necessarily in danger of dying and not related to the traumatic event. So if they experience an unrelated psychological crisis, they might dissociate when thinking about that. And just kind of want to talk about it a bit because it can be unnerving for a therapist the first time you see this happen. When somebody is sitting across from you and you're talking to them, but suddenly they're not responsive, and you can kind of just tell they're somewhere else, or maybe even they're talking or yelling at someone, and no one else is in the room. It can be a little scary. I just kind of want to tell you, stay calm, and then you want to work to bring them back into the room with you. And so you say things like, you are safe. Because dissociation is often a response to perceived danger. So you want to try to get that message out there. And even if they're not responding to you, the words are coming out of your mouth. They're hitting their tympanic membrane, and they're being processed somewhere in the brain. Right? So you want to tell them, listen to the sound of my voice. Feel the chair beneath you. So orient them to the current sensations that they're feeling or should be feeling to help bring them back to the here and now. Feel the cool air from the air conditioner blowing on your face. Feel the handrails of the chair under your arms. Where are you? And then see, and typically you can bring them back into the room. And even without you working to bring them back, they'll eventually come back. But therapeutically, you want to do it a little more quickly. You don't want to wait and see what happens, because it kind of teaches them that it is something that is controllable, and you can talk to them about what to do when they feel themselves slipping, perhaps. Okay, so the experience of dissociation makes it a bit unique. Beyond that, we can think about applying Aguilera's model to working with individuals with PTSD. So some things that I want to talk about in class, so I want to just kind of tell you to think about now is, in terms of the model, obviously, how might cognition related to some event be skewed in this population? Right? So we're thinking about the perception of the event. Having PTSD and having the way you think about the world change as a result of having experienced trauma earlier, how might that experience your perception of some other event? Getting a divorce, losing your job, infertility problems, another violent attack, unrelated to the original attack. So maybe you were somebody who's a victim of rape in college, and then now they're working somewhere else and they get mugged. How does the perception of the event? How is it different for that person because they have PTSD than it would have been for somebody who didn't have PTSD? In addition to that, thinking about the situational supports, how might the nature of PTSD limit the situational supports that are available? So how might it kind of put you at increased risk for crisis because your situation supports might not be what they were before you had PTSD or for someone who doesn't have PTSD. And then the last thing under this would be thinking about coping mechanisms. What coping mechanisms would you recommend to somebody? So again, somebody who has PTSD and then they're having some other crisis. Let's take the divorce one. Given what you know about PTSD, acute stress disorder, what might be good for someone experiencing crisis with that background? And then alternatively, what things you really want them to stay away from? Okay, because you have PTSD, you really want to be careful about this particular coping mechanism. It really probably won't work for you. Okay. So I want you to think about those things in terms of using Aguilera's model. Okay. So summing up, psychological interventions soon after trauma are generally a good thing, right? There's evidence that we can be helpful and we can prevent PTSD. We can, in some people, we can reduce its duration, we can reduce its severity if we do things properly. But we can also screw it up and make things worse if we don't do things appropriately. So crisis intervention is good, but you need to be skilled in it, you need to be trained appropriately in the skill set you need. In this class, we're talking about kind of a general skill set, but when you go to work with a particular population, you'll probably need some additional training on top of that to really be confident that you're going to do a good job and not do harm. And then there are some unique characteristics of the PTSD population. So individuals with PTSD are obviously different from individuals without PTSD. And because they have these differences, crisis intervention work on other crises might be different with them than with other people. And that's something we'll spend some time talking about in class. All right, take care.